choose one aspect of your self-care workbook, what part, or what would be the most effective thing that people with depression could do to help alleviate their symptoms?
Well, the depression workbook talks about 3 evidence-based skills. The first one's behavioral activation. The second one is structured problem solving. And the third is what's called realistic thinking. Of the 3, the research is strongest for behavioral activation, which means as people get depressed, they stop doing fitness activity, they stop eating well, they withdraw from other people thinking no one's going to want to spend time with them and I won't enjoy it anyway. So they begin to isolate, and they essentially go into a kind of stasis as though they were just going to wait it out. But in fact, doing that kind of withdrawal isolation deepens the depression, gives them a lot more time for rumination and brooding on their self-destructive, self-critical, gloomy, catastrophic thoughts, and you get a kind of cycle. Then they withdraw more, they're less active, they're more into the depression, and over time it gets harder to change and fix. Still fixable, but the behavioral activation of systematically setting goals to increase your fitness activity slowly, gradually, to begin to reach out to other people again and spend time with them, turns out to be the most effective way of emerging from a depression.
Hi, I'm interested in the fact that you essentially would come in contact with the patients in a triage situation. And what this is sort of a longer term aspect. And so how do you identify people at risk prior to being in that triage situation, which has to be treated with meds?
So we're going to identify the people at risk of what? Suicide are we talking about? Or
Suicide/drug use.
Oh, okay. Before they hit like an emergency setting.
Yes.
Right. If we're talking about workers who've been injured, you want to identify those who are starting to have problems with mood, with despair, with suicidal thinking by starting to ask the question, rather than waiting until it suddenly presents. Because men, of course, are very good at hiding and denying and just not showing their distress. So you have to do a lot more reaching out, I think, with men to understand what's happening. Something that's been done in a number of settings. Australia kind of led the way. They have a program called Mates in Construction. And that's a kind of a peer support program where they would take a construction crew and they would identify 2 or 3 people who others trusted, who they would go to, who were seen as leaders or as people you could really talk to. And they would train them in identifying indications of suicide, how to have that conversation, where they should send someone. And that person would then become a locally accessible individual whom the other guys trusted and would actually talk to. So they saw them as having a special role, and they would get training, and they would help to identify individuals at risk before something terrible happened. The same kind of approach could be used with other kinds of problems. It won't work in every setting. I remember giving a talk like this, talking about this peer support or this identification kind of system to a group of individuals in the Maritime Employers Group. They were longshoremen. And I suggested this idea of recognizing someone's in trouble and having the conversation, say, by a manager or a peer. And this one person said, well, there's some of these guys I would have that conversation with. There are some others where I wouldn't touch this, mainly because he didn't want to get beaten up. So there are really different ethos, different ambience. But in a lot of settings, this peer support program, in the military, who really went with it big time, and it's been quite helpful there. This kind of peer support program, I think, holds immense power in terms of early identification and helping someone get appropriate intervention. And I certainly don't just mean go to your family doc, because family docs don't know a lot about what to do. They'll give you a drug that acts as an emotional filter, which is what antidepressants do. They limit the range of your emotional experience, which can be helpful short term, but it's a long way from an answer.
And so that would be translatable to high school then too, because a lot of kids wouldn't go to the counselor.
There are peer support programs, I'm quite sure, in high school settings as well. Again, the same concept. There'll be some people in any group of teens, of individuals, in some subculture, if you like. There's some individuals who are the go-to people, who you really do trust. They've done it in universities where they've trained some instructors who are seen as really, like there's some profs people would go to and some they wouldn't go near. But there are going to be a few profs who are seen as accessible, as warm, as relatable, and they then designate those people as the people you talk to, as the identifiers.
First, I'd like to congratulate you. It's an excellent presentation you gave.
Good.
The points were good and so forth. My question, I'm trying to sum it up, would be, is talking about men's comparatively, in comparison to non-men, let's say, I don't want to, is psychiatry the answer, or is that the problem? I could go deeper, but I'm sure you have an opinion on that if you want
Well,
to.
you know, the psychiatric system does have its role. It should be a lot more effective. It should be much more thought out and integrated into society. But, you know, when we worked in emergency psychiatry system, these were the most severe problems. These were people whose lives had fallen apart. These were people brought in by the police because they were screaming at other people in the streets, or they may have been psychotic, or they were suicidal, but they were the most acutely dangerous. So we were dealing with that very extreme manifestation. But there's a whole society out there where psychiatry really doesn't have nearly as much to offer, I think, as it ought to, or psychology for that matter. It should be much more dispersed and much more integrated.
If I may ask, I'm sure you've heard about ANCANs in China. ANCAN. An mean peace. No, An mean peace and can mean health. These are psychiatric centers in China who specialize in ideological reform.
Right.
In that way, and you're into cognitive psychology, we have people who really need it and so forth, you know. But once you see that psychiatry tends to be misused more and more often, I'd say, toward, you know, kind of discrediting people and so forth. I mean, how would your approach deal with that? Because that's part of the problem. What you're saying is true, but there is a problem of resources. Comparatively, men have a lot less resources and are less encouraged. So I know it's overall, I'd just like to see where you stand on that.
Well, I think the future is going to lie in how we teach people to cope psychologically, how we embed that kind of training in effective coping in our social institutions, rather than outsourcing human suffering to the, say, psychiatric or mental health system, which has a very limited capacity. For example, I've been doing a lot of work in workplace mental health in the last 5 or 6 years, where the mental health system has nothing to offer, and are not even pretending that they could begin to take on. Because when you talk about workplace mental health, what you're dealing with is the spectrum of psychological distress. Not just the point where somebody says, you fit my diagnostic criteria, we will deal with you, but the whole spectrum of human suffering, from milder to moderate suffering. We need to give people skills to cope more effectively across the spectrum, but that 90% of that spectrum is something where the modern mental health system has essentially nothing to offer. So it's a whole different approach that's really going to be needed.
And I see your point. Sure.
Okay.
Hi Dan, we just got a question from the live stream here, you can take a stab at it.
Oh, okay.
So the question is, how does the gynocentric bias in academic research play a role in all of this? Isn't male disposability a centrally important cultural aspect of this?
Okay, well, there's a few different things in the language and the way it's done, which get a bit of question begging there about how the language is used. So there are biases, of course, in the area of research. I think every area of research has it. And I don't think, again, the way to approach it best is to aggressively challenge the way men are being approached. I think it's misguided. I think it can really be done more effectively. But I do believe that we share a basic commitment to improving the safety of individuals in our society, to even increasing their happiness, to decreasing distress. I just think that way of going about it, to do a kind of caricatured way of understanding men, is just not very effective. I think that's the way to look at it. Let's just look at having common goals. I believe in common aims. I don't think we're at war with each other in terms of intellectual positions, but I do believe we can look at how effective this approach is, and we can have a very interesting discussion about it.
Sorry, maybe you might have already addressed it. I apologize for being late. But I've got a question around mental health, specifically around ADHD. Because if you look at the research, 47% of prescription opioid abusers have ADHD, 22% of heroin addicts, 31% of methadone patients, And if you look at cocaine, meth, you're looking around 32-36%, or 5% of adults. And the problem in BC is the BC government doesn't take it seriously, and the medical system, including the psychological system, not saying you in particular, are not trained on ADHD, and the media doesn't take it seriously. They've never mentioned, again, the numbers I've quoted is peer-reviewed research. Right? No one in the media is talking about the connection between someone not getting diagnosed for ADHD and then boom, I found booze, or I found coke, or I found heroin, and that gives me my source of dopamine that no one told me about, no one educated me. What needs to be done by people in the mental health profession so that they start learning about ADHD? I know at UBC, the family docs only get 1 hour during their entire program on ADHD, and I've sent out a list of people to diagnose and treat in Vancouver thousands of times. We're in the third biggest city in BC.
Well, for me, the bigger problem with ADHD as it's described, given that we don't really know what it is, but in describing it as a characteristic of individuals with impulsivity and attentional problems and so forth, we should be emphasizing much more the training of individuals to cope more effectively and not emphasize so much the mass provision of stimulants as the answer to that. The literature on the long-term outcome of stimulants is simply not very impressive. These are not great outcomes. I think we could do much more around the well empirically demonstrated behavioral interventions to help people deal differently with their behavior and so forth, instead of immediately reducing it to a biological problem which simply requires that kids be given stimulants. I think we've gone way too far with that approach, and it would worry me if much more were being identified if that were the limitation of our approach, is all we could do would be to provide stimulant medication. I think we'd be doing a disservice to boys.
But you've got psychologists who are not trained on it. You can get a PhD in psychology and have no training on ADHD. So there's not that.
Yeah.
People aren't trained to diagnose, and not just.
The psychologists I know who work within the youth system are very well trained in recognition of the ADHD category as is described. So they're definitely well trained in doing that, and that's a lot of what they use psychologists for in the youth system and children's hospital and so forth. It's certainly one of their key questions. So I don't think they're not trained in that. It may be that all psychologists get somewhat limited training overall in ADHD, but certainly those who focus on the child and youth system are very well trained in that diagnostic practice.
Hi, a couple of questions. Do people take fentanyl knowing that that's what it is? And if so, what category of people are they as opposed to those who get it mixed in with something else and don't know it's there?
That to me would be part of exactly the kind of research I would like to see. It may have been, something like it may have been done. I think it's starting to be done now. And you really want to know, what are the trajectories, what are the patterns of use that lead to these horrible outcomes? What proportion of people think they're taking some other drug that they believe is not very harmful, but in fact this is what they're giving? And this is of course changing, it seems like month by month, as criminals discover that it's a lot cheaper to get a bunch of fentanyl out there than to get the other kind of drugs. So it's a problem that literally is changing its profile. It's in motion. But I think we should be doing real-time kind of research to see what proportion of people, what the messages are they're getting, and what prevention might look like with people who think they're using some other drug. And is this some teenager using it at a party, or are we talking about someone who's into an addiction lifestyle, who's just getting what they can? That would change your prevention approach. So I haven't seen firm data or good data on what the actual breakdown is of what proportion are getting it that way, but it's important to know because it changes how we prevent it.
Yes, but I'm unaware, and that's why I'm asking, are there people, anybody, who's going out there looking only for fentanyl and taking fentanyl knowing exactly what it is?
As far as I know, there are definitely a proportion of people who are looking for that super intense effect and who see it as wonderful enough it's worth dying for.
The next question is, if you were to look at and run the graphs and statistics on heroin in terms of the gender and all the things you did with the fentanyl, would you expect to find a similar profile?
I would. I would have to go back and check that data, but I certainly would expect to see it.
Hi, thank you. Yeah, I really enjoyed the presentation. But I'm from Camel River, and I came down here today specifically for this. And what I found I work with men back home, is that it's the dismal lack of services for men that's available that actually perpetuates this whole issue, whether it's fentanyl, whether it's alcohol, whether it's cocaine, whether it's suicide, because it's almost impossible to catch the guy before he gets to this point, because he's got nowhere to go. The only person that, and I used to run a program for 9 years in a men's recovery house, and their counselor was the local bartender, because that's the guy who they could sit and talk to. So really, I think that as far as resources go, we need to do something or lobby the government to at least give us, the ability to set up resources, more resources for men, in order that we, give them a chance at least, because a lot of them don't have a chance.
And I think if we planned our mental health or psychological care services in a rational way and they were integrated, we would recognize that there are certain groups to whom we must reach out in a way that will be acceptable to that group. And we should be organizing our mental health care services in terms of what the need is, which in this case would be a specific way to address or connect to men and therefore do it differently. What we tend to do is say, well, we've built it. This is what it looks like. You come to us. If you don't come to us, you're not our problem. So we do this kind of planning around a building. So here's the mental health care building. You have to come to it. If you're not going to come to it because you're not comfortable with it, and instead you're sitting in the bar talking to the bartender, we're not going to reach out to you. We're not going to find a way to make the access so easy. Doesn't tend to be what we do. It's what we ought to do. We should be planning all of our services around the actual needs, and that would mean increasing accessibility to men. It could mean increasing accessibility to particular subcultural groups who are not accessing it. We then should be out in the community redesigning our services to fit the needs and preferences of the target groups, but we don't tend to do that.
No, we don't, and I actually did work for mental health and addictions also, and you had to have an appointment, and you were given an appointment, 8 days in advance at 3:30, and here you go, you have to be here now. The need is right now. So yeah, I think the system fails men great.
Yeah.
So, how do I phrase this? It seems to me that the perception in society is that depression is something you suffer from, and it's kind of external to you. And you're presenting a model where there are things that you can do without drugs to address it. So, that combined with the fact that part of what you're trying to do is to help men realize that they're suffering from a depression or from, I don't know the exact psychological terms, but so how do you navigate the dual kind of ethical societal issues of what people might accuse you of victim blaming by saying that you're telling depressed people that there are things they can do, that it's them, they can fix it. And I don't agree with that, but it is an argument that would come up. And also, how do you avoid turning the men into victims when you help them accept that they can have something that they can fix?
Well, the question of victim blaming by teaching people how they can manage it more successfully would be akin to saying to someone, you can not get this kind of cancer if you avoid this particular kind of toxic substance in your workplace. Now, by doing that, I'm not blaming the victim. I'm showing someone what they can do, or if you have such a condition, these are the things you can do that will help you recover from it more quickly. Again, in healthcare, in physical healthcare, you don't get accused of blaming the ill person by showing them what they can do. When you go into hospital and you have surgery and they give you this extensive package of recovery activities you should do afterwards, it simply makes sense. And most people say, that's great, that's what I need to do. Again, you're not blaming the person who has the injury or the illness. You're showing them how they can be part of the recovery process. Was there another question in there that I missed? Was there something else?
How do you avoid once someone realizes that they have a mental illness, how do you avoid reducing their agency? 'Cause
Right. The whole term, the concept of mental illness, that whole conceptualization is fundamentally problematic. It always has been. From the beginning, when people began talking about mental illnesses by analogy to physical illnesses, it was pointed out that this is an analogy and not a very good one. That mental illnesses are really not like physical illnesses at all. For one thing, there's no demonstrable physical pathology. And it's important to remember that because it's actually hard to believe that major depression is talked about. Authoritative people say it's caused by an imbalance of the serotonergic system. There's no evidence for that. It's been looked at millions of times. There's no evidence that there's anything wrong with the serotonin system of people with severe depression, nor that when their serotonin system works again that they get better. Those fundamental tests of any illness, the logical ways of demonstrating that there is an illness, have never even begun to be satisfied. So when people talk about mental illness, it's an analogy, and it's never been more than that, or a metaphor. So those critiques that were advanced in the early 70s by then very brilliant individuals like Thomas Szasz have literally never been refuted. They've simply been ignored for a long time. If you say something long enough and authoritatively enough, people will assume it's been proven. They'll assume it's real. But it's an arbitrary kind of reality. So I don't use that language anymore. I'm out of the system. I don't have to make diagnoses. There's a spectrum of human suffering and distress that takes different forms. There's extreme sadness and despair. There's fear and anxiety and worry and tension. There's a lot of things people experience that are very painful, where they can learn ways of coping more effectively. And sometimes one of those drugs is a way to help them get through a really bad time. Someone who's suffering in the midst of depression or despair, whatever we call it, it's an agonizing state. And sometimes I say, look, you need to get through this. So we have antidepressant drugs, which, as I say, are emotional filters. They will limit your suffering. They'll also limit your happiness, but they will filter this in a way that makes it much more tolerable. But longer term, as soon as you stop taking an antidepressant, your risk of developing a depression is back to where it was before the treatment. But if you've had a course of cognitive behavior therapy, there's a 50% reduction in likelihood that you'll become depressed in the years following. So there are skills that will help you not become depressed and recover from it more quickly. And there are drugs that have a relatively short-term utility by limiting emotional distress. They're a filter.
What's your thoughts on ending prohibition? Would that help get to care directly, as opposed to, one of my thoughts is you're not going to get any help from your corner drug dealer, so to speak. So do you think that there is some steps or a way we can get to that point where we can just eliminate the stigma of taking hard drugs, so to speak?
Yeah, so one of the approaches has been a general move towards legalizing drugs, identifying the problems, providing a lot of support. We have some of those interesting innovations happening here in BC around harm reduction, a clinic where people who are severely alcohol addicted can go and they're given alcohol and they're monitored, and the rate of terrible things happening goes down enormously. It becomes much safer. The safe injection sites that we have here, instead of getting all caught up in arresting everyone who may be using these drugs, turns out not to increase public safety or individual safety very much. It's just not that effective an approach. So ending a kind of prohibition, ending the rendering something illegal as the approach, and coming up with these other approaches where you want to minimize the harms and protect people and have them right out where you can see them and keep them safe, along with some social messaging around it being unacceptable and terrible and we don't like it, and like tobacco, I think you can really start to see some powerful impacts on problematic drug use.
First, I want to thank you for your remark about Dr. Szasz, Thomas Szasz,
yeah.
And people kind of forget him. Which brings me to, the whole idea of psychiatry as an instrument of politics, which is the other side of psychiatry. I agree with what you say, there are some good, Personally, I see that as a way to circumvent courts. The psychiatric diagnostic, the condemnation, which will be with all the stigmas and everything, which will tend to be much worse than 6 months of jail or 2 years of jail. There's no limits to the, well, my point is, don't you think that psychiatry profession should in Canada, I mean, apply the section 11 of the Charter about due process? I mean, once somebody is in the end of what it says is talk about coerced psychiatry, it's against that. Coerced psychiatry cannot solve anything, cannot cure anybody because the person never came here with his or her consent or a will to change. You cannot force somebody to will something, you can force to make believe he wills. So wouldn't you think section 11 should be the guide of the psychiatric, I know it's a big thing, but that might help a lot, don't you think so?
Much as I'm willing to give opinions about almost anything at the drop of a hat, I think I'll draw a line right there. That's a bit outside of the scope of what I'm doing.
I just want to make a brief comment. I was actually for the fellow that came from, was it Campbell River?
Yeah.
Yeah. I just want to say, have you heard of a fellow named Jeff Connors by any chance?
Sorry, who?
Jeff Connors. I just want to mention him because he gave a great presentation at the University of the Fraser Valley Advocacy for Men and Boys. He works with men, he's a counselor, and he's developed some very interesting creative programs to bring the knowledge or the treatment or the information to the men rather than trying to attract them to the hospital or the treatment center. And I think there was an example he gave where he organized it with a hospital, and basically a group of nurses went to a bar where all these guys are drinking, and basically said, okay, like let's get you some information, and apparently it worked really well. So anyway, I can talk to you afterwards, and I'll get you connected.
Great.
Dan, could you go back to your slide on the how clinical researchers view different masculine stereotypes? I got a little lost on that. It was on this one. Of gender studies researchers. If you could just explain that one more time.
Okay, it's a test called Conformity to Masculine Norms Inventory, I believe. I think it's CMNI. And it's meant to be a measure of hegemonic masculinity, meaning that how someone reacts to this shows how much they tend to embrace what is believed to be the primary form of masculinity in our society, this hegemonic masculinity. So individuals are given a large number of items. These are sample items from the scales, and they're said, how much do you agree or disagree with this? Right. Now, in the actual studies, when they did it, most men pretty much disagreed with these things, but they disagreed with it a little bit less than the women did in their sample. Therefore, it's interpreted as men agreeing with the statements, which is sort of crazy. But the main point there is the actual scales themselves are indicative of which masculine characteristics were chosen to be included in the scale. There is a feminine norms equivalent, which is a lot nicer in terms of the scales. They're really nice. They're really nice characteristics. But for the men, there was a tendency to choose characteristics from masculine identity and features that were not very nice.
So gender studies is basically a bunch of feminists.
That's kind of, I mean.
Yeah, I've heard about it. I hope it is not actually used in psychiatry. I haven't heard
No,
it actually used
no, it's
there.
not used in the clinical world at all.
Yeah.
It's a research instrument in that world.
Yeah, feminist.
But again, the research world has its own source of funding and resources, and I would love to see research dollars allocated to answering questions in a really accurate way, because that's what it's for.
So fem's point, it would be like men would say, defining, here's the characteristics of women.
Yeah, it'd be like men with a particular bias, an intellectual bias, identifying women by scales like fear of violence or lack of honor or something like that, like something that would be just incredibly unfair. So it's just that it's not a great strategy scientifically to make sense of this phenomenon. It's just not the best way to do it. It's to
make the great strategy to make sense of this phenomenon. Could you explain a bit?
Sorry, what?
Could you explain when you say strategy? Could you explain what you mean by
Well, any scientific program of research has a general approach to understanding the area. And if I were studying depression, I would want a scale that reflected the way depression or despair is normally experienced and make sure it was reliable and valid and all that stuff. so we could measure depression, see how it's distributed, what we should do about it. If I'm studying masculinity, I would want a scale that had quite a broad coverage of features that might be considered not very good and features that are really impressive and noble and brave and all those key characteristics, and then try to understand the complexity of different kinds of men and different forms of masculinity. So it would just be a much more varied and less evidently skewed approach to the field.
Sort of getting back to the point I think we communicated today, I lost a son to fentanyl overdose. So I've spent the last year going from every avenue, understanding it from NA rooms to treatment centers. Bless you. You guys do so much great work working on that. To understanding, underfunding, to understanding why we have pill cutters for sale, which is oxy theoretically being uncrushable now, prompted fake oxys and fentanyl to boost it, to be hidden in. So my question to you is, you realize, and this is probably why you have this lecture right now, the clock is ticking, the fuse is going down. And how do you need data to move anything forward, correct? What is your time frame and how much data do you need to come to a conclusion to bring this forward at a more frontline level?
I think this needs to be set as a priority in terms of a research funding initiative like right now.
Yeah.
And I think government, provincial government in this case, the Fed's probably going to take a long time to move on this, should be allocating money and saying this is what we want, which is how research competitions work. You say, here's the problem, this is what we need to know. We need to know it within the next 6 months, which is a short time frame for research, and then look for bids of people who are willing to go into that data, into existing databases. You take each case and you say, what happened here? What happened before? What do we know about this person? You do interviews, you look at databases, you find out who those people were, and you develop a kind of cluster analysis of what their characteristics, and then you start recommending this kind of case is most preventable with this kind of intervention.
Right.
Any research program takes a year to do, but you start with the 6 months of analyzing the profile of the clusters of people who are dying that way. You now have a good sample, sadly enough. You say, how can I make sense of this? What would prevention look like? And then you do a prevention trial. So that would be, for me, a priority in health research funding right away. It's interesting is after I made some comments in that CBC podcast, just thinking this through, I got an email from a researcher who works with government in Victoria who said, I agree, we need to do trajectory analysis. We need to look at how people, the pathways to that thing. We don't assume we understand who those 100 people were who died. We walk it back and we say, who were they over time? And that will tell you what prevention looks like.
I lost my 24-year-old nephew to fentanyl overdose 2 weeks ago. Still a bit of shock processing it, trying to figure it out. He was a good kid, grew up out in Fleetwood, Surrey. There was some alcohol issues with the parents, but he seemed to be doing quite good up to about 22. Had a decent job, he had a girlfriend, and then all of a sudden something went wrong. And it was an alcohol problem initially, and for about a year he tried to just battle it on his own, and then he started going into rehab in Burnaby and in and out of rehab. And then in a matter of about 2.5 months, so basically from Jan 1 till now, he went downhill, first with heroin and then, to the final end 2 weeks ago. And apparently he was introduced to heroin by somebody at the rehab, and the rehab was for alcohol, and then it went from there. I'm wondering just what your thoughts are on the rehab programs and about when you're, I'm angry just personally because of that guy who got him onto it, and I'm just wondering, is that the right way of doing rehab, or were they not watching out enough for these types of situations? And I have a lot of thoughts in my head. Maybe you kind of get where I'm going. But.
Well, it may have some overlap with the problem of imprisoning people for drug use is historically, it's been obvious for a long time that you're sticking people in an institution where they will be surrounded by people, many of whom are much tougher and crueler and harder than they are, and that the odds of coming out of there with more problems than you walked in with are pretty high. So prisons have never been known as being very good at making people better people with fewer problems. Put someone in there and they'll probably be a rougher criminal when they leave than they were when they went in. And maybe some of the same issues arise with rehab centers where they don't carefully divide people up in terms of where they are in the process of the addictive lifestyle, of the drug-using lifestyle, of who they are, that maybe throwing everyone in together, saying you all share addiction, therefore you all belong in the treatment together, may not be accurate. Maybe they're very, again, different kind of stories or narratives or types of people, and maybe we need to be much more specific about who we put together. It's more expensive and possibly better. So I'm just throwing that out there. I don't know all the research on rehab. I know some of the research on Alcoholics Anonymous, that 90% of alcohol abusers won't go into AA and don't like it, but of the 10% who go in, they do pretty well. So we know that we need more kinds of alcohol addiction program. We need the non-AA programs, the SMART programs that are non-religious in nature, etc. And maybe we need much more variety in terms of what rehabilitation looks like.
Back on your word map, it was, I think, very tiny, hard to read even from this close, but it was the word stoic. And I was wondering if you have any opinions on kind of the stoic model of male mental health, with that approach, because that one gets thrown around in as kind of an opposite path to take from the openness to talk about your feelings path, and that kind of ties into like how do you if reaching out to people and talking to people is an integral part of healing, how do you handle introverts or people who have poor social skills in that capacity?
It's interesting how Stoicism has been grossly simplified for the purposes of our research. Actual Stoicism is a fascinating approach to being human, to being alive, to how you live. It's extremely complex, and it's pretty wonderful. So what we do is we take one aspect of it, which is you're stoic, it's a personality characteristic, you don't talk about what's going on inside you. The reality of who people are, as I learn every day when I'm doing therapy with them, is that they're very complex, and there are no simple models for making sense of it, and no straightforward rules. You must talk about your problems. It's true in therapy, I need to kind of know what people are dealing with, but how they work through it, what their solutions look like, to the extent to which it involves sharing with other people, the extent to which it involves writing for themselves, the extent to which it involves some kind of creative activity or productive activity or leaving people and going out in the woods, is very different from one person to the next. So I think we make a huge mistake by this kind of generalization or simplification of what it takes for humans to repair their souls. All the mysteries that were ever present for human happiness have not gone away, and they have not been taken over by the clinical system, which grossly exaggerates its knowledge. So that attitude of respect for the individual's particular path, their own specific journey, I think is very, very important. So for some people, it's talking about it, it's sharing, it's being in a group, it's opening up. For some people, that makes them worse. For some people, all that talking about it actually intensifies the experience and is horrible. There are others who really need to do some of that opening and some of that talking. What men tend not to do, that women are better at doing, is not venting their emotions. It's not getting sympathy. It's collaborative problem solving. And it took me years to figure that out. What's the difference in women getting together and talking about their relationships with each other? Is it that they're sharing their pain? Is it that people are saying, well, that's really difficult? I think no. I think they're doing problem solving. And they're learning from each other's experience and trying what I do with people's behavioral experiments, doing different things, approaching it differently, thinking through the relationship in a different way. And I think it's what men have traditionally not done. Tried to solve it, figure it out themselves. And that can be kind of a difficult way to solve problems. It can be cool to have someone bouncing off other perspectives. So, and I don't think there's one right way or the Stoicism is bad. Stoicism is a very powerful philosophy. And I can understand those soldiers on the battlefield not talking about their distress, not venting about that, getting the job done, and then dealing with it differently when they get home.
I just wanted to start with an observation. It's interesting, this idea of like the nurses going out into the bar and meeting potentially suffering people there. It makes me think of evangelism, of all proselytizing. But in a good sense, like, and it's almost like a shame that we don't do that outside of like a church or whatever other religious context. Go out and actually bring people into a place where they're appreciated and cared for. But my question is actually, what do you think that we could do, take away from this talk, as citizens of Vancouver or British Columbia, to mitigate this problem and make it happen less often? Like, what should we do in our day-to-day and advocacy or thought, practices?
Well, first of all, those self-care guides are really helpful. They're things that are free downloaded. Everybody should have a copy.
I actually downloaded, I did that when I was going through depression myself. So.
Wonderful.
Yeah.
So made them widely accessible. I said everyone should have this. It should be basic, distributed, freely available knowledge. It's based on all the research we've done, and it seems to be kind of where the findings are. These are really helpful skills. You shouldn't have to pay me all this money to learn this stuff most of the time. Sometimes you do, and then feel free. But what individuals can do, one thing is to pressure the government to fund proper research into this. What the government's response so far, I believe, was to open 20 new fentanyl treatment beds for women. So I believe that was their response so far. That's what I've heard about. They should be doing way more than that. There should be a much more serious investment in serious research about this issue, and there should be pressure on them to do it. Token responses are not good enough. So that's one thing. Just the way, doing business the way we've always done it is not working. This is sending us a clear message that the way we're handling drug addiction and problems so far is kind of failing with 100 deaths a month. Obviously something is not being done right. That's a fundamental challenge to the system. You don't fix it with Band-Aids. You go in there in a much more basic way. So that's another aspect, is some way of pressuring the government to come through in a serious way about this subject. Beyond that, it's the way we reach out to each other. And when you see someone who you think may be going through a bad time, to get a little freer about asking that question, about what's happening with people, how they're handling that breakup that they just went through, things that women are probably more comfortable asking and men have been less so. And maybe that's something, again, that needs to shift.